Hello, I'm Karl Robb.
And I'm Angela Robb. And in today's episode,
we talked to my movement disorder specialist and neurologist, Dr. Stephenson.
So please join us.
Thank you for joining us today. I'm Karl Robb. This is Angela Robb.
Hi, everyone.
And we're grateful to have we're very fortunate to have my neurologist and friend Randy Stephenson
with us today.
Yeah.
Oh, you're off camera again, Karl. I'm gonna have to move it.
and I'm moving today.
Gotta love dyskinesia. It always seems to come up at the most appropriate.
Oh yeah. Yeah, it always does.
Okay.
On the spot dyskinesia for sure.
So, Dr. Randolph R. Stephenson is MD is a board certified neurologist, movement disorder specialist at the Neurology Center of Fairfax in Virginia. He received his undergrad at the University of Maryland, Baltimore. He received his MD from Georgetown University in Washington, D.C. He did an internship at Albert Einstein College of Medicine in New York City, where he completed his residency. He did his fellowship at the University of Pennsylvania at Parkinson's Disease Movement and Disorder Center in Philadelphia.
Can you do that line again?
Let's try that again.
Sorry to make you do it over again, Karl, but
that's fine.
He did his fellowship at the University of Pennsylvania Parkinson's Disease Movement Disorder Center in Philadelphia. He's been a private practice since 2009. He's been my neurologist since 2009. And I'm really honored to have you here today. Thanks for
Oh man, it's an honor to be here.
Thanks, man.
Thank you for having me.
Oh, it's great. It's good. We wanted this for a long time, so I'm glad
I think he just wanted to turn the tables and put you on the hot seat.
Totally.
No. Anytime we get to talk to a neurologist, I think that's a great opportunity for the whole community, not just for ourselves.
So sure. It's a good opportunity for me too.
I got to ask you, neurology. How did you choose neurology?
Neurology. I always liked how neurology kind of made sense at least when I was learning about it in med school. And I think for me, neurology, not movement disorders, but neurology, one of the most fascinating parts of it was you could find a problem, see a problem in somebody, and then correlate that problem with what you see on neuroimaging, like on a brain MRI. And for some reason that fascinated me. It just made sense. And in neurology, I learned after becoming a neurologist, often does not make sense. And you do not always find the answer or an explanation for why something is happening to somebody. But, it sure seemed that way when I was learning about it in med school.
Well, this is on the list, but that's got to be a frustrating. I imagine it's got to be a frustrating part of being a neurologist. I guess
it is. It is when you can't give someone an answer. And I've learned, and it's, I think what bugs me the most about it is I know how frustrating it is for me, and I just can't imagine how frustrating it is for a patient to not be able to get answers. And in that scenario, I try to emphasize to patients, saying that, I may not find out what's wrong with you, but at the very least, I can tell you what you don't have. And we'll rule out the really bad stuff. We'll make sure whatever's going on here right now is not going to get you in the end. And if we don't come up with an actual diagnosis, at the very least, we can put you in a situation where you're more comfortable with your symptoms, even though what you're experiencing is not necessarily normal.
Well, and it's kind of an art, isn't it? It's more art than anything in trying to create the palette of a little bit of this, a little of that.
Yeah.
Find what works is kind of.
Yeah, it's not always just pure science.
Well, and I guess I take that a step further in that everybody who walks in your door or is in your exam room, you have to look at them as an individual with a generic kind
Absolutely.
of formula, but then you customize it based on.
Absolutely. And that's one of the things that drew me to Parkinson's disease is, one of the things I like about Parkinson's, my patients don't necessarily like it, but when a patient invariably asks me, what should I expect? And I have to tell them, I don't know, because everybody's different. And, I think that, the immediate reaction to that is usually, well, that doesn't help me. But as you grow to live with Parkinson's disease, one of the things you need to learn is to be more flexible and adaptive and to kind of try to take things as they come instead of trying to live life in the future. And that's, I think, the hardest lesson, not just for people with Parkinson's disease, but for people in general, is you want to try to predict, what your future has, and really nobody can. I always tell patients, who have Parkinson's, I'm like, look, I can't tell you how this is going to progress exactly. I can't tell you what symptoms you're going to have when. But what I can tell you is that this should be a slow progression. If it's not slow, if it turns out that it's a quick progression, then we have to rethink the diagnosis altogether. And I like to tell patients that, Parkinson's usually is not what gets you. I can't tell you what you're going to be like 20 years from now, 15 years from now. But on the other hand, this is not something that's going to get you in the next 5, 10 years. It's or 15 years. I can't tell you that you're not going to get hit by a bus tomorrow, or, something else is really bad is going to happen to you. But, it's probably not going to be the Parkinson's disease.
As I often say, and I'm sure you say the same thing, Parkinson's is a marathon, not a sprint.
Absolutely.
Well, and I think from a care partner family perspective, that's probably what you just said is the hardest thing for people to understand. Like, they want to have a clearly defined trajectory. Like,
yeah.
Give it to me now.
Yep.
Do I need to do all the things I want to do right now, or do I
Right.
And I think that's probably one of the hardest psychological things to get over, or is that propensity to want to know the entire timeline ahead of time. And
Yes.
and I think
Yes.
that causes a lot of mental stress and physical stress.
Absolutely. Yeah, just having a diagnosis, in and of itself is hard to deal with for a lot of patients. And, it totally rocks your worldview when you get the diagnosis. Usually it's like a lot of people, when they hear they have Parkinson's disease, have lived their lives, just assuming they're healthy, and anything, bad that happens to other people. And then you get told this diagnosis, and your brain, it's really difficult to wrap your mind around that, and it rocks your worldview. Unless you're somebody who's experienced medical challenges previous to that. But then it becomes an opportunity too for a lot of folks. And this is one of the things that I try to teach, piece of advice I try to give my patients is, this is an opportunity for you to become the healthiest person you know. And a lot of patients take that to heart and follow suit. So, it doesn't have to be what defines you, as a person.
Well, what do you think makes a good care team?
I think first and foremost, you need to have, if you need to have a family, if it's a spouse or a partner, or, in some instances, people don't have those things, but they have a child that takes an interest and ownership of helping to care for you. Sometimes it's a parent, not usually, but sometimes. But you need to have a partner that helps you through the whole journey. And unfortunately, not everybody has that. And that's when you really got to reach out to the community, either through, religion, or support groups. But you can't do this on your own. So that, I think, is the key piece. And when that piece is lacking, I think that's where people struggle the most. And then, it's important to have a doctor who understands Parkinson's disease and who sees it all the time. And, there's some good primary neurologists out there that do have a fairly good understanding of Parkinson's and an interest in it. And as long as they have a good understanding and a good interest in it, then that can be sufficient. But if that's not the case, then you need to find a movement disorder specialist, I think, to help guide treatment decisions.
And I think there's a shortage of movement disorder specialists. I think we're getting more.
I think in general you're right. Fortunately, in the DC area, there's quite a few of them, for whatever reason. But yeah, in general, it's hard. It can be really challenging to find someone who
Randy,
is trained.
For 1 second, can you talk a little bit about why movement disorder specialists have this affinity to work with people with Parkinson's? Can you explain that? Just, I know that's a long, it could be a long answer.
Yeah. Well, so, movement disorder specialist, just to clarify for folks who don't know, is a board certified neurologist. Well, they don't have to be board certified, but they should be. Neurologist who's graduated from neurology residency, which is 4 years, and who has then gone on to do another 1 to 2 years of fellowship training at typically a movement disorders center or Parkinson's disease center, just in Parkinson's disease and other movement disorders. And then once they graduate from that program, they're a movement disorder specialist. So that's what defines a movement disorder specialist. What draws them to that field is probably quite variable. But for me, what drew me to the field was when I was in residency, a couple of things. Number one, I've always had tremor, even in childhood. And in residency, I actually started out as a general surgery resident, and I had problems with tremor, which prompted me to approach the neurology department at the place where I was doing my residency. And so I was able to meet one of the movement disorder specialists there to help diagnose my tremor and tell me what my options were. And ultimately, I had to leave surgery because of my tremor. I just could not make it work in the operating room. And I knew immediately at that point what I wanted to do. I had to make a quick transition from surgery to something else if I wanted to be a doctor. And I knew immediately I wanted to do neurology. And when I started neurology, I had exposure already to the movement disorder specialist in that department. And I really found her to be a good doctor. And that I kind of glommed on to her as a mentor. And then I realized that movement disorders was such a fascinating field because what really drew me to that specifically is it's a very visual field. So a lot of medical conditions you can diagnose over the telephone sometimes, or by reading a chart and looking at tests. In movement disorders, you have to examine the patient and you have to see what the movement is. And that for me was a huge draw to movement disorders. And then Parkinson's disease, which is probably for most movement disorder specialists, the hallmark of movement disorders. What really drew me to that specifically is it's such a treatable condition. And you can actually make people better. And so I found that very rewarding early on. So I kind of knew pretty quickly what I wanted to do. And also my father-in-law at the time had been diagnosed with Parkinson's disease. And so I had kind of a special interest there as well.
I want to touch on COVID in a minute and how that's affected, that's changed things a little bit. But back to the care partner. I always say you see your doctor, you see your neurologist maybe two or three times, maybe 4 times a year at best, and there's all that time in between seeing your neurologist, and those are all important times, but there's so much in between time to be doing stuff for yourself.
Yep.
To create a care partner team for your voice, for your exercise, for your physical therapy, for your massage. So many things to be trying in between, along with taking your medicine management and timing and stress level. There's so much to balance, and diet
Yep.
and sleep. But all those combined can fluctuate your illness. But I think don't you need a village to take care of your.
Yeah, absolutely. Yeah, your team. Yeah, and I obviously left off, physical therapist,
You went
your
the right way.
support group, all that stuff is key, and those things come into play at different points of your life, of your Parkinson's life. And it's different for everybody.
I think your point though is the foundation.
Yes.
Like it
starts
right. Yeah.
with the patient themselves first.
Yeah.
Although I
yes.
patient. But first you have to get your mind right and wrapped around what you were saying. The diagnosis isn't hard enough.
Right.
But then after that, you have to start building those layers, and obviously, the next layer would be you need to have a partner.
Well, first, I think first you need to build a relationship with your neurologist, and that's.
I think they're kind of the same time.
And
right.
And get over and get the motivation to get moving and to stay moving and to stay active. And get over the denial and the love of your couch.
Yep.
The couch is great, but you're not gonna get much better sitting on your couch unless if you're meditating. That's okay.
Exactly.
Yeah. Well, but I think it's a hard hurdle, Karl, wouldn't you say, from the initially, to take the responsibility. I think back to what Randy said, you're going through your life, everything seems great. Maybe you didn't take a vested interest in your health before, but this is the this is the fork in the road,
Yep, this is your opportunity. Exactly. Yep.
I can say I'm in better shape than I have been for a long time, at least physically. Although my shoulder hurts a little bit from boxing 3 days a week, and RSA boxing has been great for me.
No, it really is an opportunity. I mean,
and it was COVID.
Take charge of your health.
And COVID has helped me improve my speech because of online exercises from the Voice Project. And I completed the Speak Out program because of that.
Yep.
So there's lots of COVID, and you and I've done some telemedicine, which it's saved both of us. It saved me driving to the office and sitting in the waiting room and being exposed. It's been very, very, very beneficial. I think for less stressful. It's less timely, less expensive for gas and time and.
Oh yeah, I mean, there's I think after COVID goes away, we're going to be left with this ability to use telemedicine, not for everything, but, for a lot of things. And especially if you're established already with your doctor, what's going on, the diagnosis, it's very useful. And there's lots of folks out there who have Parkinson's disease, and it's a real hardship for them to be able to come into the office for whatever reason, if they're in assisted living or if they live far away, if they don't drive, and they have to depend on someone else to get them there. So I think the telemedicine or the virtual medicine is here to stay, and it's definitely got has a role in your, in your fight with Parkinson's disease.
It also allows you the neurologist to see at least a little bit inside where we're walking and what our surroundings are too.
Absolutely. And it allows me to see what the inside of people's homes look like, which I love.
Well, and I'll shoot in for the caregiver part and say, it's such a stress for, people who are caring for someone with Parkinson's to get them to the office if they are mid-stage or late-stage Parkinson's.
Yes, that can be a huge challenge.
Huge challenge if the meds aren't working well at that particular moment. If
they're freezing, and then that they're a fall risk, getting to them to the office is challenging and sometimes a little bit dangerous. So yeah, absolutely.
Not to mention driving on the Beltway, but that's a whole nother.
Absolutely. Oh my gosh.
I'm fine with it, but other people aren't.
No, I know. I hate driving on the Beltway. I hate it.
Or any metropolitan area that has to deal with.
Right. Right.
I'd like to go back for a second and, obviously, Parkinson's is a movement disorder, but, some of the most debilitating things that I see in the community is the non-motor.
Yes, I agree.
And how do you kind of coach or counsel, the person with Parkinson's and the family members or the caregiver, care team, whatever, about how to manage that?
Yeah, that it is often the hardest aspect of Parkinson's to treat, because you have this whole host of non-motor symptoms, sleep problems, mood problems, cognition can be affected, you have decreased executive functioning. Sometimes you can have memory problems. Some patients obviously develop things like hallucinations, which is often in response to some of the medications that they take. And how you address those, each one of those things can almost be a visit in and of itself. And they can be really challenging. I would say the hardest things to treat are the sleep issues, because there's not really a good medication to treat the sleep problems, or at least the sleep fragmentation, where patients wake up a lot in the middle of the night and have problems falling back to sleep. That can be very difficult to treat. Some of the executive functioning issues can be hard to address. Sometimes memory can be impaired. Mood can be a challenge to address depending on the patient. Patients often want a pill to make something better, and there's not always a pill that's going to work. And mood is one of those issues. yeah, you can take an antidepressant, but that's going to be helpful to an extent. But I think what's really important, if you have significant issues with anxiety and depression, is that you work with somebody who understands sort of behavioral ways of addressing anxiety and depression, and also understands how to restructure sort of your cognitive errors that people make that often lead to anxiety and depression. So, and specifically, I'm talking about cognitive behavior therapy, because if you can find somebody to help you work on that and use that approach, it takes a lot of effort and time. But if you can, if you can become skilled at dealing with your mood issues on that particular level, it will give you the tools that you can actually use down the road. And when the medications don't work, for your anxiety and depression, because you can only go up so high on mood medications, and they have side effects and potential drug interactions. And so when it comes to mood, I think patients need to learn how to take responsibility for, working on their mood specifically.
I would say I'm not a doctor at any cost, but I have had Parkinson's over 30 years, and I found working with the meds, timing the meds right, and working with outside complementary therapies have been very, very beneficial for me. With using massage, and I found that stress can make your symptoms a lot worse. And also can add to and then that can affect your all your symptoms. I think it can affect your sleep. It'll affect your mood. It'll affect,
even to the point of sometimes stress doesn't seems like the medications don't work as well when you're stressed.
Absolutely. Because especially if you have tremor and dyskinesias.
And I know from prior a few traumatic events from death of a parent, and can initiate that. I had a period where I didn't know what was going on, and I realized it was stress from that
Grief.
from the grief. And once I dealt with it, everything got better.
Or at least,
yep.
I think that's where the cognitive behavioral therapy was. We did go see a counselor, and she did give us
great
that helped us, kind of get through that period.
Yeah,
that's great. That's great.
Well, and Randy, how do you do people readily tell you that stress might be a part of it? Is that something that comes out when you're having your appointments, or do you find that's difficult sometimes for people to kind of talk about some of those mood related type situations?
Yeah, but I think people have gotten better at it. I think it used to be a bigger problem than it is now, for some reason. I don't know if it's because of COVID or it's just becoming more, acceptable to, talk about mental health. But before, it would be almost impossible to get a patient to admit to you that they're depressed. And maybe they may not even realize it themselves, And I think, society is getting better at acknowledging mental health issues. And so my patients, I notice, are more readily admitting that, hey, I am really anxious lately. I've been really anxious. Or I think I've been kind of depressed, and I hear that more than I used to.
That's good.
Well, I guess apathy, when apathy gets for some patients gets involved, they can't distinguish those diagnoses. Are you do you see a lot of that? Do you see a lot of apathy that where the patient cannot make that announcement?
Excuse me. Do I see a lot of
Do you see sorry, you see a patient being sometimes apathy, where a patient may be depressed or maybe may not
apathetic?
Yes.
Yeah, which is, actually part of that whole Parkinson's personality that I learned about when I was in fellowship, where patients, at least they come across as being apathetic. And so there's this traditional Parkinson's personality where patients are apathetic and they do not, they steer away from novelty seeking behavior, meaning they don't want to try new things. I think, but I do think you have to be, I see a lot of that in Parkinson's, but you have to be careful, I think, with the apathy. And this is particularly important for care partners because patients can come across as apathetic and disinterested when that actually may not entirely be the case, but they look that way because they may have a masked appearance. So they may not look engaged, but they may actually be very much into what's being said. Also, because of some of the slowed cognitive, just like your movement can be slow in Parkinson's, your thinking can be slowed. We call that bradyphrenia. And it doesn't mean that you're less intelligent than you were before you had Parkinson's, but it just takes you a longer time to get from point A to point B from a cognitive perspective. And if you're in a conversation, particularly if there are multiple people involved, more than just two, it can be hard for you to get your thought out, and it can be frustrating. So you're in a group setting and people are talking and you want to contribute, but you can't get a word in edgewise, so to speak, because it's taking you a while to think about what you want to say. And then you got to be able to say it. And then I think that becomes very frustrating for people with Parkinson's. And then it's almost like they give up. They're just like, well, it's almost like they lose confidence in how to engage and interact with other folks. And so, but then it can be very frustrating as well on the caregiver's point of view, because they look at the patient or their partner as being disinterested, not trying. And I think that's where my job comes into play, to kind of educate everybody in the room and say, look, I know that you're frustrated with your partner over here who has the Parkinson's disease because it may seem like they're not trying, but this is they're actually probably trying more than you realize. And they're probably more interested and engaged than you realize they are. So with apathy, you have to be careful. But certainly there can be an element of apathy that, comes along, and usually the basis for that is depression or, a lack of confidence and just kind of feeling like, well, I can't participate in some of these things, so I'm not even going to try, and I think that's a situation where good cognitive therapy or a good therapist can be helpful.
Well, I think I agree with you. I think it could also be a sense of direction, and maybe sometimes that's where a good support group comes in, or
yeah,
friends,
absolutely,
or some sort of motivation that from an outside source.
Yeah,
or from a good book, or something.
Well, and I kind of agree with what Randy said,
Yeah.
that you may be internally motivated,
Yeah,
but you're just either not comfortable or not confident enough to take the first step,
yeah,
or you're in the middle of taking the first step and then something happens and then you have to readjust, to whatever happened between the time you were taking that initial effort.
Mm-hmm.
I think that goes back to executive dysfunction, because you're not, how do you even get to step 2 if you're having step 1, or you go to step 1 to 4 and you miss 2 and 3, because it's not quite.
Yeah.
It's like putting a puzzle together. How do you approach putting the puzzle together? Do you do the outside?
Right.
But yeah, what I hear you saying is cognitive behavioral therapy is not just good for the person with the diagnosis. It's good for the family and the team or whoever to understand, because I think propensity is, we jump in and we should just hold back and wait. And I think, doesn't society kind of sometimes say, well, you should just go ahead and jump in, no dead air.
I think a lot of Parkinson's.
Right.
I think a lot of Parkinson's is being okay in your own skin and understand your limits, and sometimes pushing those limits a little bit to see what if you can make yourself a little better, but within reason, not to risk your.
Yeah.
As long as it's not too risky or too expensive within something.
Right.
But at the same time, you should be speaking to your neurologist to say, hey, this thing is going on.
Can you help me with this? And,
because we may have some way of treating it or addressing it.
Yeah, it's not always a pill or there's other things out there that you can recommend that we haven't thought of.
I hate
exactly
the hope component.
Yep, absolutely.
And I think if you don't have hope and you're working with someone who's not providing some level of hope, then it might be time to think about getting a new team member and finding somebody who's going to be hopeful with you. So.
Oh yeah, that's, I think that's one of the most important things that a neurologist or a movement disorders person, as your kind of your team leader, can bring to the table, is you've got to have, you've got to have this overall sense of hope and positivity. And, there are times where you need to have an appropriate sense of concern and where, you're not going to blow certain things off and recognize, okay, we have to address this problem. But at the same rate, you have got to make sure that hope is always there, and if you can't do that, then I think you got to look for another field, because hope is always there. I mean, there are times certainly where people are really, really sick, and then you recognize at that point this person is not going to get better. But most people with Parkinson's disease don't make it to that stage in Parkinson's, because a lot of times they just don't live long enough. It speaks to the slow progression of the disease.
That's really helpful. That's really great information. And this has been great, Randy. One quick question to wrap up things. What are your top 3 pieces of advice for any patient of maybe a newly diagnosed, mid stage, and later stage? What would you?
So a lot of it we've talked about or we've touched on. Number 1 is become the most healthy person you know. Number 2 is you have got to exercise. You've got to find a way to exercise. And I suppose that figures into the healthy comment. Number 3, you have to recognize that this issue or this problem is not just your problem, it's also the problem of whoever your partner is. And it's their disease too. And you've got to find a way to deal with it together. That is not always going to be the situation, though. Obviously, not everybody is fortunate enough to have a partner. And in those situations, that's when we need to be creative and make sure that, you're not fighting this disease alone. But those would be my 3 main things.
Would you also add that they're not just going to do so much within the confines of the time, and that the person with Parkinson's needs to take some ownership of the illness?
Absolutely. I mean, and as is true for any, condition, absolutely, you have to take responsibility for your Parkinson's. And it's, I'm fortunate to be practicing, medicine and neurology in an area where people have they tend to be kind of highly motivated people to begin with. And there are areas of the country where that's not the case, where people take a much more passive role in their care, and I don't think they do as well as a result. But that's what I love about, this area. It's people tend to be very compliant, but they tend to make sure they educate themselves. And they take a very active role in dealing with their Parkinson's. So it certainly makes my job a lot easier.
This has been great, Randy. Thank you so much for your time and
Thank you.
this is, really enjoyed
I
this.
think you've covered a lot in a short period of time, and we could probably have this conversation for a few more hours, but
I know, right? Yeah, it's been so much fun. Thank you so much for having me.
Thank you, Doctor.